Hello, everyone. I'm Dr. Randy Beck, and welcome to Autism: A New Approach. I'm really excited that you've been able to join us for this presentation, and I am hoping that you'll get something new out of it, or you'll get some kind of idea or inspiration to help someone you know, whoever you're looking at this presentation for. And at the end, we will answer some most frequently asked questions. And if you have any other questions after that, you can email us at ifn.net.au, and we will direct those questions to the appropriate areas the best we can. Now, I'm going to be joining you in the top right-hand corner throughout this presentation, and hopefully we can bring some new information to you and create a relationship which will keep you coming back, because we have these presentations frequently on different topics. So without further ado, let's get at it. So hi, here I am up here in the right corner, and we're going to be talking about, focusing for a few minutes on neuroplasticity and what it is. Now, neuroplasticity is probably one of the most exciting things in neuroscience that we've been able to use to help people over the last 10 or 12 years or so. And we're starting to realize how we can use neuroplasticity to help people that have had dysfunctions in their brain or dysfunctions in their nervous system for a variety of different reasons. Now, neuroplasticity is actually the innate ability of your brain to change based on its environment, the environment you find yourself in. And this has been very beneficial, throughout the course of human evolution. But now we're starting to realize that we can harness this neuroplasticity in a way that we can help people. So it's your brain's response to stimulus. We can use that response to stimulus in a variety of different ways to help people, which we're going to talk about over the next slide or two. So as I was saying, the neuroplasticity is basically the ability of your synapses. And the synapses are the areas in which your neurons, which are the cells inside your brain that cause us to create electrical activity that results in us being able to do things and be aware of things. These little synapses are areas where the nerves almost touch, but they don't quite touch. And this little space in between allows neurotransmitters to be able to move across them and bind to receptors on the other side. So the important thing is that when these synapses become well used, or when they have lots of activity or lots of stimulus, they become stronger or strengthened. They become a more apt pathway for the brain to use. Now, the opposite is true. When there's not enough stimulus, these synapses can weaken. Now, in our approach to to therapeutic neuroplasticity, we can use both the strengthening component and the weakening component to help people based on where they find themselves or what conditions they have inside their brain and how their brains are functioning in response to whatever situation they are in. Now, over the years, we've treated a variety of different conditions, and some of those conditions are listed here, in which we see that we've treated people with epilepsy, seizures, strokes, OCD, anxiety. Now tonight, in this presentation, we're going to be focusing on autism. And autism is a very interesting and prevalent situation that some people, adults and children, find themselves dealing with. And so before we start getting into the neuroplasticity in more detail and the autism part of the presentation in more detail, I just would like to show you a video that was produced in collaboration with our clinic in Singapore. And this video just highlights some of the patients that we've dealt with before, and it'll give you an understanding of the response that they've had. So I hope you enjoyed that little video. Now I want to talk about therapeutic neuroplasticity and what it is. Okay, so therapeutic neuroplasticity is the ability to take that natural or an innate neuroplasticity that you have inside your brain and actually guide it or harness it to do what we want it to help you have a more normalized brain function, or help the person we're working on have a more normalized brain function. Now, I know that a lot of you have probably been to other treatments or have undergone other treatments. We know that most of the patients that come to see us have been to at least 6, sometimes 7 other treatment modalities or treatment regimes before they come to see us. Now, sometimes you've had results, sometimes you've had minimal results, sometimes you've not had results. And so you're probably saying to yourself, well, what's different about how you apply neuroplasticity than these other people that I've been to, or these other treatments that we've been to? Now, we're going to talk about some of the other traditional treatments for autism later, and we'll point out some of the benefits, some of the things that may not be so good about them. But the point is, now I want to just take you through a little bit about why we're different and why we might be able to help you and other people couldn't. Okay? So we are researched and evidence-based. Now, when I say that, what I'm talking about is the treatments that we use. So the actual stimulus treatments that we use have all been from evidence-based literature. They're all from clinical studies, and we know that where they go in the brain and how they help you and how they work. And so that's the treatment component of our system is completely evidence-based. We've been doing this now for over 10 years. We've got probably the most experience clinically in the world treating using neuroplasticity techniques. It's 100% personalized for you, and we'll get into how we do that later. It's beautifully non-invasive, so we don't have to give you drugs, we don't have to do surgery or inject anything inside you, and but we can work in conjunction with drugs or with other treatments or other therapies that you may be having at the same time. And so we're totally medication free, as I mentioned before. So we have a few very good positive attributes that we hope will be able to help you in any way that we can with the topic that we're talking about tonight, which is autism. Now, often one of the questions that people ask is, well, how do you do this? How do you make this neuroplasticity stuff work? Well, we do it by a very detailed knowledge of neurophysiology and neuroanatomy. And the pathways that we use are actually neuroanatomical pathways that are present, but may not be delivering the stimulus in the appropriate amount or the appropriate frequency or the appropriate to appropriate functional systems that need to be stimulated. So we can use these peripheral systems, and we can use these naturally occurring stimulus pathways inside you to aim our stimulus into the areas that they need to go. Now, another example of this is this next slide, which shows how we would use sort of different areas of your hand and different stimulus modalities on your hand. So, for instance, temperature or even motion, sometimes even pain. But we don't use pain a lot because people don't like that. But we can use pain if we wanted to. So it shows the pathways and where they go in your brain. And over the last sort of, at least, especially the last 5 or 6 years, we've gained a very, very detailed understanding of where these pathways go in the brain, and not only where they go in the brain, but where they go after they've been processed and modulated inside the brain, which is even more important. So we get a very detailed understanding through brain mapping technology that's available today. And the brain mapping technology that we use is first rate, cutting edge, very, very powerful to guide us to where the issues are in your brain and where we need the stimulus to go and where we have to, and what types of stimulus and the amounts of stimulus that we need to change the way in which your brain is working. In order for us to get an accurate understanding of where things are going in your brain and how your brain is functioning, we need to find a way to measure that function. And we use EEG to measure the function inside your brain. And EEG has been around for a long time. It's valid, reliable, it's non-invasive, and it gives us an electrophysiological measurement of how well your brain is doing in a variety of areas across your brain. So we take the signals from your brain and we amplify those so that we can see with our eyes and have other technology like topographic maps, like are shown in this picture here, the red and green and blue little heads. And then we can continue to analyze that data even deeper and drill down into it more, and get, with our low resolution electromagnetic tomography, which is the last two pictures on the page, or the bottom two pictures on the page, with the last picture on the page, or the bottom picture on the page, showing us a 3D sort of understanding of what's going on inside your brain. Now, bear in mind, when we're measuring or using an EEG, we're not putting anything into your brain. We're not stimulating your brain in any way. We're just measuring what's actually already happening there. So we're not going to change your brain by measuring the function in that brain with an EEG. So now that we've had a little introduction about how we measure brain function and what neuroplasticity is, we're going to delve into a brief overview of autism spectrum disorder. Now, the reason we call it a spectrum is because there are a variety of different a variety of different categories, or a variety of different variations of what we would consider autism. And so We even want to talk in terms of autisms instead of autism, because we know that if we have 10 children or 10 people in a room and they've all been diagnosed with autism, they may have 10 different, totally um, different personalities, different ways in which they act, different ways in which the autism has affected them. So it's a very useful concept to think of autism as a spectrum or as a number of different autisms rather than just strictly one situation. Now, the way in which autism is diagnosed is through criteria in this Diagnostic and Statistical Manual of Mental Disorders, and it's commonly called the DSM-5. It was just recently updated, and you'll see most of you will have been fairly acquainted with these criteria. This is a simplified criteria. There's a lot more detail inside the manual itself. But basically, we have persistent deficits in social communication, social interaction, and these also must be in sort of multiple contexts, not just in one sort of social interactive context. We need also, there's restricted and repetitive patterns that are observed, patterns of behavior, patterns of interest, or even activities, a patterned activity that we see. They're saying the symptoms must be present early in development, and that they must cause some kind of clinically significant impairment in either social, occupational, or other important areas of functioning in reality. And basically, they also have to not be able to be explained by other intellectual disabilities. So it's quite a wide-ranging criteria, and one that we will see is very, very difficult sometimes to get similar diagnoses from different practitioners. Now, I always think it's important also to talk about some additional things about autism that you may or may not know, or that you may have heard wives' tales about, or some kind of rumor or myth. First of all, the cause of autism is not known. Now, we know that autism is composed of different subgroups, and this is where the term autisms, like I was talking about before, have come from. And so we see that some of these categories or some of these different subgroups do have a genetic link or a genetic component. So evidence in some of these autisms, there is a genetic component, but we have not found any single sort of susceptibility gene for autism that is consistently demonstrated across the majority of cases. Now, there's no biological markers for autism that we have that are reliable to date. So what does that mean? It means we don't have a test to diagnose autism. There's no blood test. There's no scan that we can do that can basically say this is autism or this isn't autism. And so, like many other psychiatric-like diseases, autism is diagnosed by behavior. And that means that it's open to different interpretations from different clinicians. So occasionally we do have misdiagnosis. Occasionally we do have people diagnosed in the wrong categories. They have, this is a very common occurrence, and it's one that we are aware of, but it's one that is very, very difficult to confront. Now, we do know, and I alluded to this before in the presentation, that there was a study done in 2006, and it said that basically most families with an autistic member in their family have tried at least 7 different treatments. So we know that a lot of the treatments out there don't do 100% efficiency. Some don't do any efficiency. Some are partially effective. So it's in this vein that we're presenting this tonight for you, so that you can be exposed to maybe something you didn't consider before, or a new treatment, which is potentially what we're offering you tonight. Now, there are some basic, wide-ranging theories about what causes autism and why autism happens. And some of them are based around the cerebellar connection with the cortex, so they involve the cerebellum and the vestibular system, which then would move into through the brainstem gut issues and things like that. So the cerebellum autism connection, cerebellum cortex autism connection, is a very favorable theory. There's lots of different loops that connect from the cerebellum to the cortex, and these loops are involved in a lot of the areas that are involved in autism. So there's a lot of excitement about our understanding now, and about our ability to measure some of these things with the new technology and to move us ahead. Now, there's also another category where neurotransmitters are involved, another category where actually functional systems inside the brain are involved. So we're going to have a little bit of a look at all of these, and then we'll move into some current treatment methods or some traditional treatments, and then we'll discuss what we do. Now, the cerebellum is projecting to a variety of different areas. In fact, it has wide-ranging projections to the cortex, or to the part of the brain that does the thinking. And it involves the prefrontal cortex, the motor cortex, limbic system, which is the emotional control system, sensory system, and coordination, movement, that type of stuff from the cerebellum itself. Cerebellum is also deeply involved in learning and putting things in the right order. So sometimes when emotions are not in the right order, or muscle movement is not in the right order, we get symptoms that look like autistic type behaviors. Okay, now I'm just going to move now to another slide that's going to show us a much more detailed connection from the cerebellum to the cortex. Now, this slide is showing some very interesting and new technology that can measure the tracks that are involved in different areas of stimulus inside the cerebellum. Now, we've color-coded these at least a little bit. We've tried to color-code these. So the green areas are basically emotional interaction, social processing, irritability, that type of thing. And those are the central areas of the cerebellum, and they're also the central areas of the brain. So they involve like the limbic areas of the brain. The anterior lobe are the red areas, and they're more like involved in stereotypic repetitive behaviors, motor impairments, that type of thing. Now the purple areas are, again, a bit into stereotyped repetitive behaviors, maybe a different type of behavior, different area of the body involved. And then we get to the blue area, which is the blue right-hand side of the cerebellum is projecting to the left-hand cortex. And in that left-hand cortex, we have areas of language and social cognition, theories of mind, and face processing abilities. So sometimes certain types of autism can't understand facial expressions very well. And so that's one of the reasons that there's a bit of excitement about this cerebellar cortex connection and how it can contribute to the development of autism. Now, the next area I would like to talk about is the neurotransmitters and their involvement in autism. There's a huge number of neurotransmitters and neuromodulators inside the brain, obviously, and but these four are probably the major ones that have been looked at or that we understand to be involved in autism. And these are acetylcholine, dopamine, serotonin, and noradrenaline. And we used to think that we would look at them in isolation. So we would do studies on dopamine, we would do studies on serotonin, but now we realize that it's actually a mixture of all of these neurotransmitters together that are how the brain actually performs its function in reality. Now, this slide just illustrates how different overlaps or different concentrations of these different neurotransmitters can add together or mix together to give us different components of behavior, different components of mood or different emotional expressions. So norepinephrine, usually associated with some kind of attention, motivation, pleasure, reward system. Dopamine, alertness, energy. Now we now know that dopamine is also very involved in the reward system and keeping our attention on something and involved in learning. Okay, and then we have the serotonin, which is usually associated with obsessions or compulsions or that type of stuff. But it's where they overlap that we see that all three of those neurotransmitters overlap in mood, and maybe more serotonin, dopamine interact for anxiety, and it's quite possible or mostly likely probable that this combination of neurotransmitters is also involved in the production of autistic behaviors. Now, as I was mentioning previously, autism also involves some complex functional anatomy, and we have lots of different functional projection systems inside our brain, and this is where, through the cerebellum and through direct brain stimulus, this is where we have harnessed this therapeutic neuroplasticity to be able to help people with a variety of different conditions, including autism. And so this diagram outlines the connection between the cerebellum, the brainstem, the basal ganglia, which are motor control areas inside the brain, the prefrontal cortex, the motor cortex, the parietal cortex, and the temporal cortex. So the functional connections go through multiple areas of the brain. They're highly interconnected. And so, for instance, we take one aspect of autism where a lot of autistic children don't speak, or they don't speak well, or they don't have a language that we understand. And in order to get a sort of meaningful communication or meaningful language in any person, we have to have about 10 or 15 of these different areas of the brain functionally connect at the same time. And even if 2 or 3 of those aren't functionally connected, then the language or the communication is affected, and it's not optimal. And in fact, sometimes it doesn't happen at all. Now, I thought in this presentation that it would be good to have a look at some traditional approaches to treatment, just to, if you aren't aware of these, then maybe you'd like to try them. If you have tried them, maybe they've worked, maybe they haven't. But some people aren't affected or bothered by the fact that they're taking medication. Other people don't want to take medication. Some people don't believe in, the pharmaceutical approach. Some people don't believe in the nutritional approach. Some people, everyone has their areas of comfort. So I just thought I'd go through a few of these traditional approaches, and then we'll talk about what we do at IFN to help people with autism. So the first area of traditional treatment is in behavioral intervention type therapy. And the gold standard in this area is the applied behavioral analysis, ABA therapy. And these therapists and this therapy is focused on addressing behavioral problems, not just in autism, but in many types of situations. In autism itself, there has been controversial or not consistent results reported in the literature with ABA therapy. Some reports have actually said ABA therapy is detrimental in some aspects because it is too regimented. Other papers have found that there was a beneficial effect with the ABA therapy. So the beautiful thing about ABA therapy or these behavioral interventions is that we can apply the therapeutic neuroplasticity at the same time that people are also getting the behavioral intervention. So there's no problem with overlap in this particular treatment. In fact, in all of the treatments we're going to talk about, they can all be taken on or performed at the same time as therapeutic neuroplasticity, even pharmaceuticals, which was a great transition into the medication-based treatments. Now, basically, the medications that are used for autism are a range of antidepressants, antipsychotic, anticonvulsant, sometimes stimulants that are used. So they're drugs that are used for autism that had been developed for other things. So we call this off-label prescribing. Okay, so basically a survey that was done. I can't remember the year, but I think it was a couple of years ago. Found that approximately half of the children with autism have been or are on an antipsychotic or a psychotropic drug. Now, most commonly, antipsychotics are used to alleviate mood or behavioral disturbances, mostly irritability, sort of uncontrollable aggression, and agitation, that type of thing. Now, the first generation of these drugs focused mostly on dopamine, so that they were stopping dopamine from joining or binding to the receptors in the postsynaptic cells. So remember before, earlier in the presentation, I talked about the neurotransmitters. Well, the dopamine, these drugs block that dopamine. Now, the second generation of drugs mostly, well, they do block dopamine too, but they also block norepinephrine. Now, I have a little bit of a diagrammatic representation of this just so I can show you the difference. These are two drawings, representations of neurons, and we've blown up the part of the neuron that is the synapse, so where one neuron comes in contact or almost in contact with the other one. And basically, the one on the left-hand side is the dopamine blocker. So that's mostly the first generation of these drugs that were used for antipsychotic drugs. And the one on the right-hand side is showing the blocking of that serotonin. So again, we go back to that soupy mix and the appropriate mix that's necessary for behavior and for the brain function. These drugs are attempting to modulate or alter that mix to get it into a range that is more beneficial for the person. And in a way, the stimulus that we're using for the neuroplasticity also works at these synapses and in a way is trying to do the same thing, except we're not using a pharmaceutical to do it. Now, one of the biggest considerations with using pharmaceuticals or any type of medication is that there are side effects that we need to consider. Now, with these particular drugs, so with the antipsychotics and the antidepressants, biggest problem is weight gain. So they will cause weight gain in people, weight gain in children, and it probably is, in the long run, probably one of the most problem-causing or troublesome side effects, because overweight or obesity can lead to other more serious situations when they're older, like diabetes, hyperlipidemia, cardiovascular disease, all types of things. So that is not a trivial consideration. So if you're going to be on these drugs for long term, we have to consider how we're going to modulate or mediate that weight gain throughout the years as they develop. There's also some hyperprolactinemia, which means that serum prolactin levels elevate, and prolactin is sort of involved in milk production and mammary development. Extrapyramidal symptoms are another problem in some of these. What we mean by extrapyramidal symptoms are involuntary sort of movements. So, and these movements are not normal movements, they're abnormal movements. And they've also been described as dyskinesia, or dyskinesias. And a lot of these dyskinesias will occur when you stop taking the drug. So we call them tardive dyskinesia. So that means that when the drug is starting to reduce, that's when these sort of erratic, involuntary, abnormal movements start occurring. Now, of course, we also have to consider the sedation that these children might be under, or the adverse cognitive effects of having, antipsychotic drug floating through your brain. So, we don't have a lot of information on this yet. In fact, some of these drugs have no placebo controls done. And then there's also hypersalivation that occurs in some kids. So they drool a little bit when they're on these drugs, and that's just sort of a societal thing, or a social norm that lots of people don't like that. Now, next on our list of traditional therapies, there are dietary treatments. And there's mainly two types of dietary treatments that we're looking at. The first one is some kind of elimination diet, where we eliminate gluten or casein. We eliminate something that we feel is causing problems in the diet, possibly sugar. And the rationale behind the dietary treatment regimes is basically that sometimes a food allergen, such as gluten, could cause activation of the immune system and cause a triggered autoimmunity, which may attack the brain and some of the functions inside the brain. So there is some data in support of this, and some research in support of this. So the elimination diets may or may not be effective. Now, also in some of these patients, we have gastrointestinal abnormalities. So they can't absorb stuff properly. And that's another issue where we get different types of bacteria growing in their intestine than is the most appropriate for them. And that's why sometimes we would give them a probiotic or some other type of dietary supplement. Now, the next area of dietary treatments, the second type of diet, is basically some kind of ketogenic type diet where we limit the exposure of carbohydrates to our digestive system, and then the liver starts converting fat to ketones, and those ketones can be used in the brain. They replace sugar in the brain, or glucose in the brain, and so they burn fat instead of sugar. And there has been a lot of work done in epilepsy or seizures, especially in children, with the ketogenic diets and the production of ketones and not using glucose. Not a lot has been done in autism, and there's a big sort of controversy between what is the right ketogenic diet. Some of the ketogenic diets are quite severe, and they're really not sustainable in a normal life. And we do know that if you have a severe ketogenic diet, you cannot maintain that, or you have to go off the diet probably every 4 weeks, followed by a 2-week normal regime, then 4 weeks back on. It's just because the way in which the liver and the kidney has to function is not sustainable, and we sometimes get some damage done to those organs with a high, severe ketone diet. And that's why the Atkins diet was brought in, probably I think back in the 60s or 70s probably. And it was a less severe ketone diet, but it still produced weight loss. Now, in order to get seizure control, we have to have a fairly severe ketone diet with a high fat content. So usually the Atkins diet isn't enough to control seizure events, and we need to go to a much more severe sort of ketone producing diet. Okay, so the trade-off is the more severe the diet, the less sustainable it is, and the more potential for damage. But the benefits of that are usually higher. And if you're going to get some benefits from that, you'll see them with a severe ketone diet before you will from the Atkins diet. Now, the next area of traditional treatments that I want to talk about is the nutraceuticals. Now, nutraceuticals are basically food as medicine. Okay, so there's foods or parts of foods or some kind of mixtures of different foods that are capsulized and then taken in the form of vitamins or capsules or liquids or creams. The interesting thing about nutraceuticals is that we often use these nutraceuticals as a treatment for a problem or as a insurance that we have enough vitamins when we start stimulating the brain or doing something else to the body. So we usually are not interested in just maintaining a sort of normal dietary allotment of these vitamins, so that the doses of these vitamins are often quite high compared to the standard daily dose that you might get from your vitamins at the pharmacy. So don't be alarmed if you go to a naturopath or you come to go to a pharmacy, compounding pharmacy, or come to us and we're giving you some nutraceuticals with a lot higher dosage than often you would be expecting in a sort of minimum daily requirement type situation. Now, the probiotics compose the next area of often used treatments. And basically, the probiotics are beneficial bacteria, for the most part, that live in our intestines, and they provide us beneficial effects. So there's two main bacteria, the lactobacillus and the bifidobacterium, okay, which we want to have a lot of those in because they help us maintain a healthy gut situation. And that healthy gut situation also contributes to a strong immune system. So that's often why we prescribe probiotics with brain stimulation, is because we do know that there is a tremendously strong brain-gut connection. And in fact, if you have a problem in your gut, you probably have a problem in your brain, and vice versa. So often these probiotics will help with things like gut inflammation or leaky gut, which are allowing big proteins to get into our bloodstream, which cause our immune system to hyperactivate, and that's not a good thing. Now, I get a lot of questions about hyperbaric oxygen therapy, and we have looked into this quite extensively. The hyperbaric, again, there's inconsistent research with the hyperbaric oxygen therapy, but what we do know is if you're going to do hyperbaric oxygen therapy, you need to use a tank that is what we call a hard shell. So a tank that can compress you down into a number of atmospheres. So there are some other tanks, I suppose we want to call them that are more tent-like, or more fabric. And what the feedback is that I get from my parents that are using these is that you have to spend too much time in them and the benefit is not that great. But what we do know about hyperbaric therapy is that it does cause oxygen to bind to the hemoglobin in a much greater concentration than normal, and that results in more oxygen going to the brain. So the downfall of the hyperbaric therapy so far is that we find that it only lasts as long as you're in the tank. Once you come out, you normalize within 2 to 3 hours. So you have to have frequent, long exposures in order to see some clinical effect. Now, chelation is also a technique or a treatment that many people try. And the chelation is basically a technique where we take heavy metals out of your body. We take heavy metals out of your blood because these heavy metals interfere with nerve function and other types of function. Lots of different enzymes are affected by these heavy metals. So we try to reduce that heavy metal load in your body with these chelation agents. Now, the downfall is that you do need to have a puncture. You need a needle, and you have to sit still while the chelation agents are being infused into your body. You have to go to a relatively highly trained specialist to get this. So there are some downsides to that. Probably one of the most highly researched areas of autism treatment is music therapy. And there are many, many studies that are showing beneficial effects of music therapy. We use music therapy as one of our modalities in our treatment. In fact, we use all of these except hyperbaric oxygen chelation and medication in combination with our brain stimulus, which we find increases the efficiency and the efficacy of the treatment and makes people more comfortable, and we get a much better result when we start overlapping some of these treatments. So music therapy, been around for a long time, has many studies done, and is probably one of the most effective treatments that we know of so far for behavioral and emotional development. Now, as I've been promising, the traditional route isn't the only one, so we're going to look at some case studies now of some patients that we have seen in the Institute and some of the results that we've got from those people. And then we'll just move right into question and answer after that. Now, our first case is this case, AB. Now, AB was a 10-year-old boy who presented to us. He had previous diagnosis of autism since the age of 4. But his parents reported that during the first 12 months of his life, he was reaching all the appropriate milestones. Then at around 12 months, he had some kind of exposure to a drug-related toxicity. He had rashes, fevers, high temperature, extended for a period of time, and then the mother basically said, I saw a significant, obvious regression in his behavioral milestone development from the time that he had that sort of fever reaction or that drug reaction. Now, his communication skills continued to regress. He used to be able to speak words, but now he doesn't speak words, he just makes sounds. He has poor eye contact. He was socializing less and less, retreating to the corners of rooms, assuming fetal position sometimes when he was overwhelmed. His growth in height also slowed over time. And so at the time of presentation, his parents were worried basically about the delay in speech, his verbal communication, sound sensitivity. He had a huge sensitivity to things like dogs barking, babies crying, sirens, over-exaggeration, emotional responses to different situations, and of course the hyperactivity and stimming. So one of his stimming behavior was to hit his head against the wall, which really, really upset his parents, obviously, as it would any of us. Now, these are the results of AD scans. So the one on the left-hand side is his original scan, and the one on the right-hand side is his scan after about 80 treatments. Now, the dark blue areas were of pretty great concern to us because when he first started, because usually in autistic children we do get this sort of widespread, what we call panencephalitic underactivity or hypoactivation, and it shows up on our head maps as this dark blue. And when we have this dark blue area going from one side of the brain to the other, we call that a functional disconnect. And the functional disconnects often produce what I would call autistic-like behavior. That's not necessarily autism, but it produces autistic-like behavior. So we see sometimes in kids that are demonstrating autistic-like behavior, we do the EEG, we find that they have these functional disconnects, but sometimes they are caused by different things. Sometimes seizure activity can cause a functional disconnect, sometimes a trauma, sometimes some kind of toxic exposure can cause them. So we want to make sure that when we're looking at the diagnosis of autism, we want to make sure that the scans are representative of what an autistic child would be like, and that the scans also, the brain responds in a way that we would expect from an autistic child. And AB just did not respond that way, because you'll see that in the scan on the right, a lot of those dark blue areas have actually started to disappear and to be filled in by, light blue, even green in some instances, which green is optimal behavior. And autistic brains just don't respond like this. They don't respond this way. So we kind of had a feeling that this might have been a misdiagnosis, even though two separate pediatricians and I think a psychologist diagnosed him as autistic when he was 4 years old. Now, a very interesting thing about this case is that without us knowing about it, the mother took AB to a psychologist, an independent psychologist, and had him tested before he started treatment, and then had him tested after 80 treatments. And the blue are the prior or before treatment, and the red are the after treatment. And you'll see that basically he had highly significant changes in social initiative, assertiveness, self-regulation, integration, and these are all in the social functioning sort of realm. And we'll see some other changes in other realms that he had in a second. So now we've moved to the learning realm, or the learning disposition realm, and you'll see that he also had massively significant changes: pleasure exploring, sensory experience, persistence, and acquired work skills. So in a variety of different areas across emotional categories, learning categories, and we'll see if he's had any other changes in the next slide. So we see that his greatest change was in the emotional realm. His self-confidence, sense of security, and ability to rest and relax also increased significantly. Now, he has been reevaluated because his mother wanted to see if she could take him to a school, what we would call a normal stream school. So he was reevaluated for his disability, and they brought back a diagnosis as a minimal classification of disability, which meant that he could now attend a mainstream school in a regular class. And that was a great outcome because when the parents first came, they were concerned that he would probably not be able to attend a mainstream school for sure, but may not even be able to attend a special school because his functioning was so low at that time. So this outcome was amazing, and we do believe that this was a misdiagnosis. So he was diagnosed with autism, but in fact he had some kind of developmental delay, which was probably triggered by his drug reaction. And that caused a functional disconnect, which produced autistic behaviors, which produced his diagnosis. The next study I'd like to take you through is a study that we performed on in our clinic in Hong Kong. And what we basically did was we took 24 patients, and each of these patients received between 36 and 72 treatments. And this is in our Hong Kong clinic. And the results of these, treatments were based on feedback from the parents. So we gave them basically a categorical chart ranging from 1 to 10, and then they indicated the degrees of improvement or regression on these charts, and then we have put them in a bar format so that you can understand in a visual way the response. So you can see on this slide, it's showing that we measured speech, irritability, anxiety, attention, social skills, memory, and general health. And you'll see that there were significant changes. So speech, a significant increase in speech, significant decrease in irritability. Oh, by the way, the blue bars are prior, so pre-treatment, and the red bars are post-treatment. So you'll see in speech, we've had a significant increase in activity. With irritability, we had a significant decrease. Anxiety, we had a significant decrease. Attention, significant increase. Social skills, significant increase. Memory, significant increase. And in general health, that was the biggest change we saw, was in the general health category. And so a lot of these kids still had autism, but they were much healthier at the end of the treatment. So we're going to move in now to the question and answer period. And what we've done is compile the number of questions that we often get after our presentations. And I'll try to answer those for you now. But like I said before, if you do have other questions, feel free to email ifn.net.au, and we will redirect your questions to whatever clinic is the most appropriate. So the first question we usually get is, how does it work? So what do you do that makes this happen? So it's a 4-step framework that we do. We map your brain using the technology that we talked about before. We basically try to understand how your brain is responding to different stimuli that we put in. We put the stimulus in, we then measure again how your brain is going, and then we remap your brain to see what changes have happened because of the stimulus. Then we go back to the step 1, and we basically put in more stimulus, and then we map it again. We put in more stimulus, and we map it again. And so eventually we get a very good idea of how your brain is responding to our specific treatment and other treatments you may be on, including medication or any of the other therapies that we talked about. So what is the first appointment like? Well, we have a consultation, which involves a physical examination and a history of your life or your child's life up to that point, with relevant happenings that have occurred to them, like with AB when he had the exposure to that toxic situation or the toxic drug. We then do the physical examination, the neurological examination, we do a brain scan, and then we take any other further information that we have, that you may have, CAT scans or MRIs or any kind of doctor reports or specialist reports. We take all that information and we then compile or compose, based on all that information, a treatment plan for you that we feel is going to be the most beneficial for you. Now, all this takes approximately 90 minutes, but in some cases it may take longer depending upon the difficulty of the case or the complexity of the situation, whether the child is compliant with our examinations. But for the most part, between 90 minutes to 2 hours, we get most of the information we need. The clinicians are highly trained and have a lot of experience dealing with children that might not want to give them the information that they're asking for, but we find a way to retrieve that information. Now, what stimuluses do you use is another question that we often get. We use a variety of stimulation techniques, and most of the, like I said, most of the techniques of the traditional treatments that I have outlined prior, we also overlap those with our brain stimulus. So we use manual therapies. So this is where we use joint mobilization, joint position, deep tissue trigger points, deep tissue massage. We use cerebellar stimulus, we use vestibular stimulus. So there's a lot of different stimulus pathways that fall into this manual therapy category. We also use visual and mental stimulus. And these visualizations or visual stimulus and the mental stimulus are usually overlapped with some other type of brain stimulus like the manual therapy or the electrical stimulus that we might be using. So electrical stimulus is usually a very light electrical current that we can put through your hand or your arm or your foot. Other types of modalities that we use electrical currents with include the transcranial direct current, which is a very, very small current that goes through, very, very small current that goes through your brain, and it just helps us to coax your brain to behave the way we want it to. We use breathing technique, a lot of breathing technique theory or therapy to try to increase oxygenation inside the brain. We use light therapy, so it's basically low-level light therapy, which is the use of lasers that can go across your skull into your brain and stimulate certain areas of your brain. And we also use music therapy, as I have alluded to before. So can you describe a typical treatment plan? What do I have to do? Or what's it composed of? Well, once we interpret and analyze the outcome of your initial evaluation, basically you're going to be coming in for a treatment plan involves 18 treatments. And these are usually 20 to 30 minutes in length, depending upon the complexity of the treatment. You'll also get some daily homework to do, so some daily home exercise, which is usually around 20 minutes. Now, it's not heavy-duty exercise like you would expect. It's some very, very simple exercises that we would use. We also will give you some nutritional supplementation, which is appropriate for your situation. Usually, the treatments, the 18 treatment package will take between 3 and 6 weeks, depending on the frequency of daily visits, obviously. And if necessary, we have what's called an intensive program. If you're traveling from overseas or you have logistical problems with time, we can often intensify the number of treatments per day so that 18 treatments can happen more quickly. Now, where are our clinics located? How do you find us? Where do you have to go? We have basically clinics, we're expanding clinics across the world. Right now we have clinics in Singapore, Perth. Well, we have a clinic in Singapore, we got 3 clinics in Perth, we have a clinic in Sydney, a clinic in Hong Kong, a clinic in China, and a clinic in Canada. If you go to our website, ifn.net.au, all of these clinics are there, and their emails and contact details are listed there, and you can get in contact with them through that means. How much does it cost? Is probably the biggest question that people will have. Unfortunately, it's one that I won't be answering tonight, based on the fact that because we have different clinics, the pricing is different across those clinics. So basically, because the pricing is different, what I would advise you to do is to go to ifn.net.au, look up the clinic that you want to go to, and then contact them, ask them for pricing details, and then they will supply the correct pricing details to you at that time. Okay, so that draws to an end our presentation tonight. And if you do have more questions, just please send them to ifn.net.au, and we will send those questions out to the appropriate clinic, or the appropriate person, and we will get an answer back to you. And really would like to thank you for attending our presentation tonight, or today, and hope that this is fun, that you found something new or something interesting or something that will help you moving forward in your journey towards the best you can be. Okay, so I am Dr. Randy Beck, and I am very, very pleased to have had this chance to present to you, and I would like to sign off by saying thank you very much for attending, and stay safe.